pura hey, arito bebé. To bebé tai sarambi perbeture Senyi agui anyanduva pura hey To petanye epote de yurupe Hapuka vupe se anyua Rei potaro e gerurente Peisajina Paraguay Paipuque la Emiliano ta ipuque la Yambay Yahamino nyondive quiero que hape Torbe ape yahe sape ko Aguille manteame Agüeruko señe Toiko subi pura hey Albu arito bebé Aguille manteame Agüeruko señe Hey, arito bebé, aguille manteame.
Ya sea cuaraje, todo la veima, o cañen boracu, donde el reina, tapere, me hueca tú te quiere o yo quiere, ya jamón bebé.
Subi pura hey, albu arito bebé, aguille manteame, agüeruco señe, pero subi pura hey, albu arito bebé, aguille manteame, agüeruco señe, pero subi pura hey, albu arito bebé, aguille manteame, agüeruco señe, pero subi hey, arito bebé, aguille manteame, agüeruco señe, rico subi pura hey, arito bebé, aguille manteame, agüeruco señe, rico subi pura hey, arito bebé, aguille manteame, agüeruco señe, rico subi pura hey. Arito bebé, to bebé tai sarambi perbeture Senyi agui anyanduva pura hey To petanye epote de yurupe Hapuka vupe se anyua Rei potaro e gerurente Peisajina Paraguay Paipuque la Emiliano ta ipuque la Yambay Yahamino nyondive quiero que hape Torbe ape yahe sape ko Aguille manteame agüeruco señe Toiko subi pura hey albu arito bebé Aguille manteame, agüeruco señe, rico subi pura hey, albu arito bebé, aguille manteame.
Ya sea cuaraje, todo la veima, o cañen boracu, donde el reina, tapere, me hueca tú te quiere o yo quiere, ya jamón bebé.
pura hey, halbu arito bebé, awi llevante a me, aweruko señe, rico subi pura hey, halbu arito bebé, awi llevante a me, aweruko señe, rico subi pura hey, halbu arito bebé, awi llevante a me, aweruko señe, rico subi pura hey, halbu arito bebé, awi llevante a me, aweruko señe, rico subi pura hey, halbu arito bebé, awi llevante a me, aweruko señe, rico subi pura hey, halbu arito bebé, llevante a me, aweruko señe, rico subi pura hey, halbu arito bebé, pura hey. To bebé tai sarambi perbeture, señe awi anyanduva pura hey. To petanye epote de yurupe, apoka vupe se anyua. Rei potaro e yerurente, paisajina Paraguay. Paipuque la Emiliano, ta ipuque la Yambay. Yajamino nyondive, yero khape. Torbu ape, yaje sape koe. Aguille manteame, agüeruko señe. Toiko subi pura hey, halbu arito bebé. Aguille manteame, agüeruko señe. Toiko subi pura hey, halbu arito bebé. Aguille manteame,
Ya sea Cuarajú, todo aveima, o cañemborajú, doye veima, tapere, de hueca tú te quiere o yo quiere, ya jamón vuelve. Ya sea Cuarajú, doble aveima, o cañemborajú, doye veima, tapere, de hueca tú te quiere o yo quiere, ya jamón
aguille manteame,
vuelve.
agüeruko señe. Toiko subi pura hey, halbu arito bebé. Aguille manteame, agüeruko señe. Toiko subi pura hey, halbu arito bebé. Aguille manteame, agüeruko señe. Toiko subi pura hey, halbu arito bebé. Aguille manteame, agüeruko señe. Toiko subi pura hey, halbu arito bebé. Aguille manteame, agüeruko señe. Toiko subi pura hey, halbu arito bebé. Aguille manteame, agüeruko señe. Toiko subi pura hey, halbu arito bebé. Aguille manteame, agüeruko señe. Toiko subi pura hey, halbu arito bebé. Pura hey. To bebé tai sarambi perbeture, señe awi anyanduva pura hey. To petanye epote de yurupe, apoka vupe se anyua. Rei potaro e yerurente, paisajina Paraguay. Paipuque la Emiliano, ta ipuque la Yambay. Yajamino nyondive, yero khape. Torbu ape, ya viaje sabe coe aguille mantiame agüeru coseñe toy cosubi pura hey albu arito bebé aguille mantiame agüeru coseñe toy cosubi pura hey albu arito bebé aguille mantiame
ya se acuarahu todo aveima o cañen borahu doye reima tapere me hueca tunde que te quiere o yo quiere ya jamón burbe ya se acuarahu doble aveima o cañen borahu doye reima tapere me hueca tunde que te quiere o yo quiere ya jamón
aguille mantiame
burbe
agüeru coseñe toy cosubi pura hey albu arito bebé aguille mantiame agüeru coseñe toy cosubi pura hey albu arito bebé aguille mantiame agüeru coseñe toy cosubi pura hey albu arito bebé aguille mantiame agüeru coseñe toy cosubi pura hey albu arito bebé aguille mantiame agüeru coseñe toy cosubi pura hey
o cañen
arito bebé aguille mantiame agüeru coseñe toy cosubi pura hey
o cañen
arito bebé
doye reima
agüeru coseñe toy cosubi pura hey albu arito bebé pura hey to bebé tai sarambi peveture senye agui anyanduva pura hey to petanye epote de yurupe apuka vupe se anyua rei potaro e yerurente peisajina Paraguay paipuke la Emiliano ta ipuke la Yambay yajamino nyondive yero khape torbu ape yaje sape koe aguille mantiame agüeru coseñe toy cosubi pura hey albu arito bebé aguille mantiame agüeru coseñe toy cosubi pura hey albu arito bebé aguille mantiame
ya se acuarahu doble aveima o cañen borahu doye reima tapere me hueca tunde que te quiere o yo quiere ya jamón burbe ya se acuarahu doble aveima o cañen borahu doye reima tapere me hueca tunde que te quiere o yo quiere ya jamón
aguille mantiame
burbe
agüeru coseñe toy cosubi pura hey albu arito bebé aguille mantiame agüeru coseñe toy cosubi pura hey albu arito bebé aguille mantiame agüeru coseñe toy cosubi pura hey albu arito bebé aguille To bebe tai sarambi perveture Senye agui anyandu vapura hei To petanye epote de yurupe Apoka vupe se anyua Rei potaro e gerurente Peisajina Paraguay Paipuque la Emiliano ta ipuque la Yambay Yahamino nyondive yero khape Torbu ape yahe sape ko Aguille mantiame Agüeru kosenye Toiko subi pura hei Albu arito bebe Aguille mantiame Agüeru kosenye Toiko subi pura hei Albu arito bebe Aguille mantiame
Ya sea cuarahu Todo la veima O cañen borahu Doye el veima Tapere De hueca tunde que Te quiere o yo quiere Ya jamón burbe Ya sea cuarahu Doble aveima O cañen borahu Doye el veima Tapere De hueca tunde que Te quiere o yo quiere Ya jamón
Aguille mantiame
burbe
Agüeru kosenye Toiko subi pura hei Albu arito bebe Aguille mantiame Agüeru kosenye Toiko subi pura hei Albu arito bebe Aguille mantiame Agüeru kosenye Toiko subi pura hei Albu arito bebe Aguille mantiame Agüeru kosenye Toiko subi pura hei Albu arito bebe Aguille mantiame Agüeru kosenye Toiko subi pura hei Albu arito bebe Aguille mantiame Agüeru kosenye Toiko subi pura hei Albu arito bebe Aguille mantiame Agüeru kosenye Toiko subi pura hei Albu arito bebe To bebe tai sarambi perveture Senye agui anyandu vapura hei To petanye epote de yurupe Apoka vupe se anyua Rei potaro e gerurente Peisajina Paraguay Paipuque la Emiliano ta ipuque la Yambay Yahamino nyondive yero khape Torbu ape yahe sape ko Aguille mantiame Agüeru kosenye Toiko subi pura hei Albu arito bebe Aguille mantiame Agüeru kosenye Toiko subi pura hei Albu arito bebe Aguille mantiame
Ya sea cuarahu Doble la veima O cañen borahu Doye el veima Tapere De hueca tunde que Te quiere o yo quiere Ya jamón burbe
Awiye mantiame Agüeruco señe Rico subi pura hey Albu arito bebé Awiye mantiame Agüeruco señe Rico subi pura hey Albu arito bebé Awiye mantiame Agüeruco señe Rico subi pura hey Albu arito bebé Awiye mantiame Agüeruco señe Rico subi pura hey Albu arito bebé Awiye mantiame Agüeruco señe Rico subi pura hey Albu arito bebé Awiye mantiame Agüeruco señe Rico subi pura hey Albu arito bebé Awiye mantiame Agüeruco señe Rico subi pura hey Albu arito bebé pura hey To bebé tai sarambi per veture Segni agui agnanduva pura hey To petanye e pote de jurupe Apoka vupe se agnua Rei potaro e gerurente Paisagina Paraguay Paipuque la Emiliano ta ipuque la Yambay Yahamino nyondive Yero khape Torbu ape yahesape koe Aguille mantiame Agüeruco señe Toiko subi pura hey Albu arito bebé Aguille mantiame Agüeruco señe Toiko subi pura hey Albu arito bebé Aguille mantiame
Yase hakwaraku Dobu aveima Okanyin boraku Doye ureima Tapere de hueca tundeke Te quiere o yo quiere Yahamon gurube Yase hakwaraku Dobu aveima Okanyin boraku Doye ureima Tapere de hueca tundeke Te quiere o yo quiere Yahamon
Aguille mantiame
gurube
Agüeruco señe Rico subi pura hey Albu arito bebé Aguille mantiame Agüeruco señe Rico subi pura hey Albu arito bebé Aguille mantiame Agüeruco señe Rico subi pura hey Albu arito bebé Aguille mantiame Agüeruco señe Rico subi pura hey Albu arito bebé Aguille mantiame Agüeruco señe Rico subi pura hey Albu arito bebé Aguille mantiame Agüeruco señe Rico subi pura hey Albu arito bebé Aguille mantiame Agüeruco señe Rico subi pura hey Albu arito bebé pura hey To bebé tai sarambi per veture Segni agui agnanduva pura hey To petanye e pote de jurupe Apoka vupe se agnua Rei potaro e gerurente Paisagina Paraguay Paipuque la Emiliano ta ipuque la Yambay Yahamino nyondive quiero que hape Torbu ape ya hesape koe Agui yemanteame Agüeru kosenye Toy kosugui pura hei Albu arito bebé Agui yemanteame Agüeru kosenye Toy kosugui pura hei Albu arito bebé Agui yemanteame
Yase hakwaraku Dobu aveima Okanyin boraku Doje ureima Tapere tapere Bewe katundeke Te quiere o yo quiere Ya hamon burube Yase hakwaraku Dobu aveima Okanyin boraku Doje ureima Tapere tapere Bewe katundeke Te quiere o yo quiere Ya hamon
Agui yemanteame
burube
Agüeru kosenye Toy kosugui pura hei Albu arito bebé Agui yemanteame Agüeru kosenye Toy kosugui pura hei Albu arito bebé Agui yemanteame Agüeru kosenye Toy kosugui pura hei Albu arito bebé Agui yemanteame Agüeru kosenye Toy kosugui pura hei Albu arito bebé Agui yemanteame Agüeru kosenye Toy kosugui pura hei Albu arito bebé Agui yemanteame Agüeru kosenye Toy kosugui pura hei Albu arito bebé Agüeru kosenye Toy kosugui pura hei Albu arito bebé To bebé taisarambi peveture Senye agui anyanduva pura hei To petanye epote de yurupe Apocavupe se añua Rei potaro e yerurente Peisajina Paraguay Paipuque la Emiliano Ta ipuque la Yambay Yajamino nyondive Quiero que hape Torbu ape ya hesape koe Agui yemanteame Agüeru kosenye Toy kosugui pura hei Albu arito bebé Agui yemanteame Agüeru kosenye Toy kosugui pura hei Albu arito bebé Agui yemanteame
Yase hakwaraku Dobu aveima Okanyin boraku Doje ureima Tapere tapere Bewe katundeke Te quiere o yo quiere Ya hamon burube Yase hakwaraku Dobu aveima Okanyin boraku Doje ureima Tapere tapere Bewe katundeke Te quiere o yo quiere Ya hamon
Agui yemanteame
burube
Agüeru kosenye Toy kosugui pura hei Albu arito bebé Agui yemanteame Agüeru kosenye Toy kosugui pura hei Albu arito bebé Agui yemanteame Agüeru kosenye
Buenas noches. Siguiendo con la enseñanza de flebología continua, esta noche tenemos como tema principal trombosis venosa profunda y superficial, y nuestros oradores van a ser el doctor Trombosis Caprini y Anil Hingorani. Tenemos panelistas de Brasil, Argentina y de Uruguay. Los coordinadores de la noche va a ser el profesor doctor Víctor Ganata y el doctor Sergio Garbaz, a quien le paso la palabra, doctor Víctor Ganata.
Much, Dr. Jorge Rios, the moderator, Sergio Garbaz. This is Dr. Ganata, and we have here the honor to have with us Dr. Trombosis Caprini from Chicago and Dr. Anil Hingorani from New York. We will talk about kind of important stuff, talking about thrombosis, deep venous thrombosis, artificial thrombosis. Thank you very much for us. We have a very good. You can start talking. Just give you the final address to start it. Manuel, puedes pasar ya el video. Sergio,
Good afternoon. It's a great pleasure for me to be asked to participate in this very important Congress and these discussions with my dear friends from South America. It's been a great honor to be associated with you over all of these years, and I would like to start by appreciating everything you've done to help promote the risk score and do it to prevent the number one preventable cause, which is fatal pulmonary emboli. Now, in 1986, we started this journey with risk assessment. And since that time, people still don't understand certain facets of it. And I would like to go through some of those things today. And what's even more disturbing to me is there have been over 200 articles in over 5 million people in all 5 continents where my esteemed colleagues have taken a critical look at the score, the good, the bad, and the ugly. And where are all those results? The 2012-2019 guidelines, first by Chest in 2012 and then Ash in 2019, there's nothing in there about all of your experiences worldwide. They're not all good experiences. There's some bad experiences. There's many lessons to be learned. All of us have to keep learning lessons and improving this process. So today what I'd like to do with all of you is to share some thoughts and some reflections about this process, and also then touch a little bit on COVID-19. These are my disclosures. Now, the Caprini score has been chosen because it's the most comprehensive history and physical available today. And again, as I say, it's been studied all over the world. 40 elements are looked at, and we know that as the number of risk factors goes up, the incidence of blood clots increases. We also know there's a power of each risk factor. Some risk factors are weak power, such as birth control pills, and some are strong power, like cancer of the esophagus or pancreas. So these factors interact and in a synergistic way come up with a number, which includes the number of factors, their relative weights and powers. And then that number is a nonlinear increase in the incidence of venous thromboembolism as the score rises. As the score goes up, the incidence of venous thrombosis goes up. Here we see the results in general surgery. Now let's go back a page to Chest 2012. For the first time, the Chest Consensus Group acknowledged the importance of individual risk assessment, whereas 4 years earlier in 2008, they were against this particular score. But now by 2012, they stated that this score was one of the scores that should be considered, and they evaluated the scores, the 3 or 4 papers that were available then, and determined that a score of greater than 5 was associated with a 6% incidence of venous thrombosis. And this number has stuck till today. And it's inappropriate today. Fine, it was wonderful when they came up with it, some very brilliant people, but not anymore. Things change. So I was very excited when the 2019 guidelines came out from the American Society of Hematology, who took over from the Chest Group, because now we were going to see, at that time there were 150 articles in 2019. Shows you how it's expanding. And I was waiting to see what they said. And they use the verbatim text. And I'd like to show you scoring systems that calculate the risk of postoperative VTE for individual patients of the Caprini score have been developed and validated following some surgical procedures, almost all surgical procedures by now. A widely used, highly quality guideline from the 2012 CHEST, which places a strong emphasis on patients' VTE risk scores, is the Caprini score. Okay, they also mentioned the Caprini score in the same sentence as the Rogers score, which was also mentioned by CHEST 2012. And there's only been 1 or 2 articles on the Rogers score, and that hasn't been adopted. The following reference was the 2005 disease a month. All the other references were missing. The meta-analysis was missing. So currently, we show that those with a score of 5 or more are high risk, but other patients with a score of 5 may be at very low risk. And let's take a look at these studies. For example, in general surgery, when the score is over 8, there's a higher incidence. In plastic surgery, over 8, it's 11%, whereas over 5, it's very low. And in head and neck surgery, practically nobody gets a clot with 5 or 6, whereas when it goes over 8, it's 18%. And you can see the populations in ICU. So the scoring system has various applications, but I'm going to show you the poster child for the United States. And if every hospital did this, we would literally wipe out venous thromboembolism within 30 days on the surgical services. This was a mandatory scoring system using the Caprini score along with mobilization, but the key was there were various groups, and depending on the group, thrombosis was mandated, and that mandate required the surgeon to agree to it before the orders could be signed, unless for a reason they needed to opt out. They could always opt out. And if the score was less than 5, they had a variety of things they could do in the hospital, and everybody complied with that. But if the score was from 5 to 8, all of the patients got 7 to 10 days of low molecular weight heparin injections. And as you can see, 89% of the population followed that. And if the score was over 8, 9 and above, they got 30 days of low molecular weight heparin, and 3/4 of the patients went along with that. Now, what happened? In the beginning, there was a very high incidence of thrombosis, much higher than the national average, which we see here in green in those services. Adopting this protocol, by July 2013, the incidence was reduced to 0.1% of all VTE, including deaths, at 30 days. And if all hospitals did this, you can see the kind of results they could get. Now, you might say, well, that's hard to do because this is probably a very famous hospital in a wealthy neighborhood where they could afford all of this, and the donut hole didn't mean anything to them. Wrong. This was an indigent hospital, and the authorities of the hospital got together with a drug company and made sure that every single patient that needed the drug got it for the period of time they needed, without any charge if they couldn't afford it. Again, the poster child for the United States. Now let's take a look. I understand that not all 200 articles would have been candidates for this very elegantly done ASH guideline. I don't want to take anything away from the guideline. It was very elegantly done at the very highest level, and I applaud them for that. But this meta-analysis was left out. And Christopher Panucci, who wrote this meta-analysis, went out and got the original data sets from the papers that he was going to do the meta-analysis in. So he redid all of the data for himself, he and his group. So it's very good data. And what he showed was patients not receiving prophylaxis had a direct correlation between their score and VTE incidence, especially 7 and above. And not only that, patients with a score of 6 or less in this meta-analysis, in the 13 studies that were looked at, did not have a significant VTE reduction with chemoprophylaxis. Remember what Jeff said in 2012? That patients with a score of over 5 had a 6% chance and should get prophylaxis. But now this is 2017. You see, believe me, I'm not trying to be critical. I love the CHEST guidelines. I love the ASH guidelines, but we have to keep up with new literature as it comes along. And all those with a patient scored 7 to 8 and over 8 had a significant VTE risk reduction using chemoprophylaxis. And the other thing that's really key about this is that if you didn't use prophylaxis, there was a 10% incidence of venous thromboembolism if your score was above 8. So that is a very powerful statement. Now let's go to Vietnam. 4 Vietnamese hospitals over a period of 2 years gathered 2 million, that's right, 2,795,024 patients. And look, we see the same things happening. As the score goes up, the risk goes up and is the highest over 8. Now let's go to China. And here we see patients in this is a lung cancer population. That low score, they didn't get a clot. A moderate score, 5 to 8, 12% incidence. It jumped to 40% when the risk goes to 9. Lessons we're learning from all of our wonderful colleagues from around the world. And these studies are very consistent from country to country when they were done right. And they are to be believed. Now let's go to Russia. Cyril Lobostov and his associates. They had a very high-risk population, and they scanned these people. And when the patients had a score of 5 to 8, there was one scan clot. But if the patients had a score of 12 to 15, there were 65% of them had a clot. That doesn't mean they were all statistically significant clinically. But what that shows you is with escalating score, there's an increase in the incidence of thromboembolism. And not only that, but you have to look at your own particular population. This Moscow hospital, these patients were very seriously ill and had very complicated procedures. So you have to take a look at that when you look at these results. Now, here's another thing which is absolutely critical. And these patients, this is another study that was done by Lobostov and his associates. And they said that patients who had a score of over 9, the symptomatic VTE incidence, now this is symptomatic, was at least 11%. And in those when the scores were 11% or greater, the incidence of symptomatic events approached 59%, despite the combination of stockings and low molecular weight heparin. So they postulated that this extremely high-risk group required improvements in their VTE prevention protocol, and escalating the low molecular weight heparin dose was one option, but that could lead to more bleeding. So they decided to do a group where they would compare this group to a group that received pneumatic compression in addition. 407 patients randomized to be their control group, low molecular weight heparin stockings, or low molecular weight heparin stockings adding the pneumatic compression. All patients underwent blinded duplex scans preoperatively, 12 hours postoperatively, and every 3 to 5 days. Low molecular weight heparin prophylaxis was given for at least 7 days or more in all patients, as has been shown over a 30-year period from all the trials. And IPC was used for 18 hours daily. The duplex ultrasound revealed that the symptomatic venous thrombosis in the lower limbs was seen in one patient who was in the combined group with the pneumatic compression, and 34 patients in the group that did not get the pneumatic compression. Remember, everybody got low molecular weight heparin for 7 days. So 5 of the patients in the control group, low molecular weight heparin only, developed PE, and 3 of them died. No PE were seen in the study group combining pneumatic compression with low molecular weight heparin. No statistically significant differences were observed regarding skin injury, bleeding incidents, or PE-related mortality or postoperative mortality. Isn't that a fascinating study? Let's go back to China and let's talk about burns. And burn patients have a very low incidence, as you can see when the score is around 5 to 6. But look what happens. It gets up almost to 9% when the score goes above 8. Are we seeing something here unique? Of course we're not. In all of these countries, with all of these wonderful investigators around the world, the score goes up in proportion to the type of population being studied, and the highest score only begins at 5. It goes much higher in certain populations. Now let's take another look at another study that was done in head and neck patients. And those patients in this study who had a score of 6 or less, nobody had a clot. Whereas when the score was over 8, then there was a very high incidence of thrombosis, and it got even higher when the score went over 10. So look at the set points in this population. Totally different population. Chest 2012, ASH 2019. Are you listening? All right, let's go back to China. And here we see a comparison of patients at risk using both the Caprini risk score and the Padua risk score. And look at this. With patients with a score of 5 to 6, a 3.3-fold increase in the incidence of VTE, 9.4-fold 7 to 8, and 24.69 if the score was over 9. Set points, we're seeing the same thing. Different country, different populations, different groups, same thing. And then besides that, between cases and controls, highly statistically significant sensitivity of the Caprini score of 80% compared to Padua score of 30%. Interesting data, isn't it? Now let's talk about, now we're going to go to Thailand. And this is a very important study in hip fracture patients. And they were having a lot of clots, so they decided to scan everybody ahead of time. And they also used a well score and D-dimer. But the real punchline of this study is that they found that 16% of the patients who came in with a hip fracture had a duplex scan positive preoperatively. And the sensitivity and specificity of the Caprini score was high, and therefore, and also here's another thing: if the score was over 13, equal to 13, there was a 60 or 73% chance that patient would have a clot. So the authors recommended that all patients with a Caprini score of equal to or greater than 12 be screened preoperatively, which has been poo-pooed in orthopedic surgery. But we're talking about hip fractures. And in this particular locality, in this particular situation, that's what it held true. More interesting data. And now we go back to New York, where they did a study of 1,078 patients over a 15-month period. And the 7 orthopedic surgeons who did hips and knees combined to do this protocol, and they had a department protocol, and they had their criteria for high risk, which were what a lot of orthopedists use. There are a few criteria. And when they looked at the results, everybody who was not considered high risk in their protocol got aspirin. And what happened was that in the department low risk, there were 7 patients out of the group. 7 of the 8 patients in the study that got a clot were classified as low risk by the department protocol, exactly parametrically opposed to what the Caprini score showed, all but 1 patient. The Caprini scores were done in retrospect after the original data was done. They went back and rescored the patients, and they found that 7 of the 8 patients were positively identified with a score of above 10. The orthopedists have yet to accept this. Since that time, they published an additional study where their incidence over 1 year was 0.2%. So it's more and more interesting data. So, in conclusion to the risk assessment part of this talk, the risk score increases in direct proportion to the incidence of clinically relevant VTE events. Identifying those at high risk varies according to the population tested, and the original concept that everyone with a score of 5+ is no longer true. As a matter of fact, in head and neck surgery, nobody had a clot in that one study. Some patients with a score of 5 or 6 may be spared anticoagulants according to the meta-analysis, if you fit that one of those trials where the meta-analysis was done. And the set point for high-risk patients needing prophylaxis, as I've shown you, varies around the world, varies with different populations, but the relative results and the relative risk reduction is similar all over the world. Now let's just briefly talk about COVID-19, and this is a very complex, multifaceted, serious infection. One of the few good things about this is that I've been able to reach out to my colleagues around the world much more frequently because I'm just sitting here in my den, and I love that. Anyway, this disease results in activation. As we know, before COVID, Hegeman factor could activate platelets to produce plugs, coagulation to produce fibrin mesh, fibrinolysis to stimulate blood lysis, and then activate the complement and kallikrein systems, the inflammatory and antigen antibody or antigenic systems, immunologic systems, without an antigen antibody reaction, all mediated through Hegeman factor. COVID-19 is this constellation on steroids, as it were. It magnifies it 100%. There's a predilection for the lungs, and Oscar Ratnoff made some very important observations that, as a part of this whole thing, we see thrombosis, fibrinolysis, increased vascular permeability, vasodilatation, bradycardia, angioedema, histamine release, and hypotension. And these are all interrelated facets, and the body looks at them as a whole, like pieces of a jigsaw puzzle, fitting into the whole puzzle. And individual pieces are fascinating, but that isn't what makes up the puzzle. And to note, and just to point out, unfortunately, although there's a lot of thrombosis with the disease, anticoagulation alone is not the answer. Now let's go forward here now to the NIH multi-platform, and it was announced on January 22nd that in severely ill patients, this is a worldwide study, very large, very well done study. In seriously ill patients, meaning they're in ICU or on or off a respirator, escalating the dose of anticoagulation did not help, and there was just more bleeding. But in the moderate risk patients, that means they're in the hospital, but they are not, of course, they're not in ICU, that the need for organ support and mortality was better, was superior using full anticoagulation compared to the usual care. And this harkens back to a principle that we put together with some of my brilliant colleagues from the American Venous Forum. And we decided, and this was when they were still debating whether or not, when patients come into the hospital with COVID, should they get low molecular weight heparin, and we heparin or low molecular weight heparin. We said they all should, but you got to score them. And that's still not being done in most of these studies. And if the score is over 8, then you double the dose of anticoagulation. And then rescore at discharge, and then use extended chemical prophylaxis for patients which have those criteria listed here, like elevated D-dimer, BMI, other Caprini score factors. We also decided to introduce this as a straw man for all of you around the world to, if you will, knock it down. And we decided that because of the thrombosis potential in this disease, we would add 2 points for COVID positivity, add another point if they're symptomatic, and add 2 more points for a total of 5 if the D-dimer was positive. And then we also emphasize that this has to be updated during hospitalization. So here we go back again to Russia, to this wonderful Moscow group with Cyril Lobostov and his associates. And they looked at 168 patients with a Caprini score, and they identified a significant correlation between the Caprini score and the risk of VTE in COVID-19 patients. That's the regular Caprini score. They did a variety of models, including the new model, which I proposed. And they concluded that the original model was appropriate enough for COVID-19 patients, and they didn't see any real advantage to use the additional model that I proposed. Now we go to Egypt. And this is just out. This is not fully published. It's just in a newsletter. But these investigators studied the direct correlation between the Caprini score and the risk of VTE in COVID-19 patients. And the score equal to or greater than 7 calculated in admission, or 11 or more at discharge, predicts symptomatic venous thromboembolism despite pharmacologic prophylaxis, intimating that maybe we need to increase the doses. The predictability of the original score may be improved by implementation of the D-dimer or the specific COVID-19 points that I proposed. However, the original Caprini score is essential. So what we're seeing with these 2 studies is, for goodness sake, do the original Caprini score, because that works. Whether or not those additional scoring factors that I proposed are going to work out in the end, time will tell. But we have all these wonderful investigators from around the world that are willing to test this. Why? Very simple. To stamp out as much as possible the number 1 preventable cause after surgery or hospitalization, fatal pulmonary emboli. Now, my hat's off, and I'd like to give special acknowledgement to my dear friend Alex Spiropoulos, because he is doing scoring in COVID-19. And he came up with a study, as you can see here, of 4,960 patients continuing anticoagulation after discharge. In 13% of these patients significantly lowered the composite outcome shown above by 46%. comorbidities, hypertension, diabetes, obesity, and cancer history. And he used his improved D-dimer score of over 4, which was one of the most important predictors of VTE risk. Hats off, Alex. God bless you and the work you do, and keep it up. Because you know what? We're all on the same page. There are many roads to Rome. So, in conclusion, I want to quote from my dear friend in Maine, never kill a friend, never treat a stranger. And what we mean by that is that when you meet somebody, you do a thorough history and physical, and in so doing, they become almost like your friend. And then, of course, you would never kill a good friend, but don't ever treat a stranger. Particularly important exercise, especially during COVID-19. I'd like to thank you all for your attention. Please view my social media platforms for more information, and have a wonderful day.
Thank you very much. Thank you very much, Dr. Caprini. It's a privilege and an honor to have you here. It was a fantastic presentation. I can say we enjoy a masterclass of risk factors and thromboembolic disease. We know your work for many years. Thank you very much. Le damos la palabra ahora perdón, vamos con el panel primero. Tenemos un panel de lujo hoy, entonces vamos a pedir sus comentarios, sus aportes, en principio al doctor Bruno Lima Naves de Brasil, por favor.
Buenas noches. Él gostaria de fazer uma pergunta para Caprini. El dímero D está lamentado en todos los pacientes que tienen COVID. Entonces, para todos, tiene más riscos de trombosis. Pero que estamos vendo agora é que os pacientes pós-COVID tienen trombosis também. ¿Qué podemos hacer con los pacientes que están 2 semanas o hasta un mes pós-COVID que tienen trombosis? Usamos algún otro Caprini score? Do you understand, Caprini? Many patients after the hospitalization or after the COVID-19, they have thrombosis again. I don't know why, but they continue to have thrombosis. So it's possible to use a different kind of Caprini score for the patients after the COVID-19.
Well, again, thank you very much. It's a real honor to be with all of you and to present these data. I had a few mistakes in that lecture. A couple times I said symptomatic when I should have said asymptomatic, but I hope you picked up what was on the slides. In answer to your question, I think it's absolutely critical. We know we did studies going back to 2008 using the REATE database that patients, as you know, the REATE database is a database of patients who developed DVT, and their doctors put in why they got the DVT, how they were treated, and their outcomes. So from that database, we see that 70% of the people in that database got their clot when they went home. That doesn't mean 70% of all patients that go home get a clot. Of the group that wound up with a thrombosis, most of them got it when they went home, and half of them after anticoagulation was stopped. That was in 2008. That data was largely ignored. We just published again, and this has nothing, the real generator behind this are Manuel Monreal and my wonderful and brilliant colleague and associate, Professor Juan Arcelas. And they just republished new data in non-cancer patients, abdominal surgery, non-cancer patients, showing the same thing. So, first of all, most people get their clots when they go home from the hospital. Now, I looked at a couple of those COVID reports that talked about the fact that there was a 1.4% incidence at 30 days in people when they went home, so they didn't think it was a problem. Classic mistake. And, you know, it's a conundrum because the people that do these trials want to be all-inclusive, and that gives them greater numbers. And of course, that gives them greater attractiveness to the drug companies because of the greater numbers to get funding. But as a matter of fact, going through and pairing out those people that are at very high risk, you would have a much better idea of who, when they go home, gets a clot and how to protect it. And that's why I applauded Alex Paropoulos. Now, we're going to have some data coming out to also show something like that. And I would say that until further notice, if the patient has a Caprini score of 8 or more, and certainly if they have a D dimer that's positive, that those patients, for sure, if they have a score of over 8, ought to go on anticoagulation for at least the next 6 weeks. And I think that there'll be people around the world that will test this postulate and refine it. Maybe it's not. I'm not saying these are like the 12 commandments, for God's sake. This is a postulate. This has to be proven with time or disproven, and I'm sure in the end the answer will be slightly different than we say now. But the bottom line is we can't just send all people home without individually finding out who has comorbidities, who can walk, who doesn't need oxygen, who still has a high D dimer, whose BMI is over 40, and so forth. Sorry for the long answer.
Thank you very much.
Muchas gracias, doctor Nave, por su pregunta. Vamos a seguir con el siguiente panelista, que es el doctor Trio Pocha, presidente de la Sociedad Brasileña de Cirugía Vascular. Adelante, doctor, con sus preguntas o sus comentarios. Doctor Antonio, está silenciado su micrófono.
Excuse me. Congratulations for Dr. Caprini. Your table greatly facilitated the prevention of venous thromboembolism worldwide. Intermittent compression is a good option for most surgical or clinical patients. In all patients, should physical methods be used?
I'm so glad you brought that up, because first of all, I'd like to come back to what is the undeniable, unreplaceable necessity during an operative procedure, especially one that lasts any period of time, and that is pneumatic or some type of compression. There's mechanical compression devices now in addition to pneumatic compression. During surgery, the patient gets an anesthetic, and that anesthetic causes the muscles in the calf to be paralyzed. And Philip Coleridge-Smith has shown that when the muscles in the calf are paralyzed, the gastrocs and the other calf muscles, calf veins dilate without the muscle tone. And then if that goes on for any period of time, and don't remember the arteries are pumping blood into the leg at all times, but now this flow is restricted out of the leg, that finally the veins will get big enough and the walls crack. And Tony Camerata has shown us beautiful pictures of a million-power micrograph of cracks in the endothelial lining, to exposing the subendothelial collagen, allowing the blood to contact that and start the process of clotting. Next, because the patient's muscles are still metabolizing, there are waste products in this pooled blood that also increase coagulability. Now, let's say the patient comes to the operating room with infection, tumor, COVID, whatever. They're already hypercoagulable to begin with. So this is Virchow's triad personified, a witch's brew of thrombosis, vasodilatation, vascular damage, and hypercoagulability. Now, if the leg is somehow straight, then the popliteal vein in about half of the cases can be shut down by the gastroc head, and therefore that further decreases the flow out of the leg. Until you come up with another way to mitigate this witch's brew during surgery, you can never get rid of mechanical compression, pneumatic compression. Number two, the study in the New England, God bless the New England. We all look to the New England Journal of Medicine. It's like the Bible. But they published this article, Prevent, and this was published with a large series of patients with multiple countries. And I would refer you to the rebuttal article that we wrote, Andrew Nicolaides, Stephen Kakos, and myself, showing that why the conclusions of that study should not be implemented around the world. And right away, when that study was put out, and to refresh your memory, that study indicated that there was no added benefit of pneumatic compression to existing low molecular weight heparin or other anticoagulants, and specifically low molecular weight heparin prophylaxis. The DVT rate was not lowered by combining with pneumatic compression devices. And there were 5 devices tried. 2 of them have no pedigree. There was no consistency in the scanning. And so you need to read that. You need to read that paper to understand why we're making these statements. And they're not negative. They're absolute facts. And we applaud the people that did the study for trying to do such a large and comprehensive study. I'm not trying to say anything negative, except that we shouldn't stop using pneumatic compression on the basis of that trial. Lobostov has just published, as you saw, when in very high-risk patients, he had 2 groups. He had stockings and low molecular weight heparin, and the other group, he had stockings, low molecular weight heparin, and pneumatic compression. And they were looking at all clots. And the breakthrough thrombi, doing the scans, occurred in 34 patients on low molecular weight heparin in that group, and 1 patient in the combined group. So at least we need to have further studies. Is that study the end all? Of course it's not. But it's an indication that if you properly risk stratify the patients, and you see, he didn't put it on all patients. They had to have a score of over 11 to get into the study. And that's the missing link here, is not doing individual risk assessment. And until this is done in all of these studies, we're not going to really get the answers that we really need.
Thanks for your response. Congratulations for your presentation.
Gracias,
Thank you
doctor.
very much. Thank you very much.
Gracias, doctor Trigo. Bueno, ahora seguimos con el último panelista de Brasil y vamos a darle la palabra entonces al doctor Altino Moraes, jefe del Departamento de Cirugía Vascular del Hospital Santa Rita de Maringá, Brasil. Adelante, doctor, por favor.
Olá, Sérgio. Gracias. Congratulations, Dr. Caprini, for a great speech. And Victor, thank you for the invitation. It's for me a pleasure to be here. Dr. Caprini, I have a question about the vaccine. What do you think about the rates about the mainly AstraZeneca and the DVT? Do you see any events about this in other vaccines like Pfizer or Moderna? Then in Brazil, it's a huge confusion about this because the patients answer every day about this. It's a confusion for us.
Right. So, especially in our country, now that Mr. Trump is gone, the news is looking for subjects, and they have really sensationalized this whole thing. And it's a shame, because you take a look at what happens if you come into the hospital with COVID. There's probably the events rates are at least 17% of DVT and around 20% of PE. But as a matter of fact, those rates may even be higher because you can't scan all of the patients that you need to just because of COVID. So that there's a, let's say, a 1 out of 5 chance if you can, that you're going to get a clot if you come in with COVID. Now, if you take the vaccine, what is it's minuscule. It's a tenth of a percent or something, 3 or 4 cases. So that's one thing. Now, I can understand all the hype, because anytime you have a serious or fatal thromboembolic event, especially right now with the sensitivity of everybody's pointing their fingers at the drug companies. And as a matter of fact, they're very rare events. And the AstraZeneca, the serious AstraZeneca event, is a reaction that occurs, an anion cation type of reaction Anil will probably explain it better than I can. But you know, when you develop an allergy to heparin-induced thrombocytopenia, where there's a paradoxical thrombosis from the anticoagulant, it's due to an anion cation reaction. And the same thing happens to a susceptible individual with the AstraZeneca vaccine, but very, very rare. And there are also thrombi that occur, but those thrombi in the millions of patients that have gotten the vaccine may be background noise. They may not be background noise. But what else is another missing link? Nobody got risk assessed. So if you're sitting there and you vaccinate somebody that has a BMI of over 40 with a borderline congestive heart failure, valvular, hypertensive valvular abnormalities, and by the way, had a past history of cancer and her mother died of a DVT, do you think the chances of that person from the vaccine, although the vaccine doesn't contain a virus, but it induces an inflammatory response, and we know that inflammation is a risk factor for thrombosis. So in a very highly susceptible individual, very, very rare, that person could technically get a thrombosis from the vaccine. But my message to people is to take the vaccines. They're thousands times safer than getting COVID and getting a serious infection in the hospital. Somebody once said that it's about getting the vaccine, thrombosis from the vaccine is like getting struck by lightning or killed by a shark during your lifetime. So, and I don't know if that's accurate or not, but it's just one way to look at it. But anyway, very, very rare. And then I would encourage anybody to take with a grain of salt all the stuff on the news, because it's just a terrible thing that we don't get all the facts. We get what will get people's eyes, and sometimes that's not what we really need to hear.
Thank you.
Thank you very much, Dr. Caprini and Dr. Moraes. Ahora nos vamos a Córdoba para darle la palabra al doctor Salvador Minoldo, que es hematólogo del Sanatorio Allende, de allí de la ciudad de Córdoba. Adelante, doctor.
Sí, buenas noches a todos y repito, gracias por la invitación. Yo voy a hacer un breve comentario acerca de la tromboprofilaxis que indicamos a nuestros pacientes al alta por COVID. Siempre utilizamos heparina de bajo peso molecular, regulando la dosis de acuerdo al clearance de creatinina del paciente y al recuento de plaquetas. Si el paciente pesa menos de 80 kilos, indicamos 40 miligramos de enoxaparina sódica cada 24 horas. Si pesa 80 o más de 80 kilos, 60 miligramos. Y si pesa 100 o más de 100, utilizamos o indicamos 80 miligramos cada 24 horas. ¿Hasta cuándo debe extenderse la tromboprofilaxis con heparina de bajo peso? Hasta que se negativiza el dímero D, porque el dímero D es un indicador de activación del sistema hemostático. Hay pacientes que a lo mejor requieren tromboprofilaxis 15 días, 20 días, 30 días. Hemos tenido pacientes que se ha extendido hasta el día 45. Pero, repito, siempre controlando clearance de creatinina y recuento de plaquetas. Con el clearance, ¿por qué el clearance de creatinina? Porque la heparina de bajo peso es de depuración renal. Si nosotros tenemos un clearance entre 30 y 59, ahí reducimos un 20%. Si es entre 10 y 29, reducimos un 40%. Y si el clearance es inferior a 10, pasamos a heparina no fraccionada porque tiene una depuración bifásica. Entonces, el manejo es totalmente diferente. No utilizamos inhibidores de última generación, tipo apixaban o rivaroxaban. ¿Por qué? Porque aprovechamos el efecto profibrinolítico y antiinflamatorio que tiene la heparina de bajo peso molecular. Debemos tener presente que la heparina de bajo peso libera activador tisular del plasminógeno y además también inhibe al inhibidor del activador del plasminógeno. Y en aquellos pacientes internados por COVID y que tienen riesgo de trombosis venosa profunda y o tromboembolismo pulmonar, esos pacientes van heparinizados con una dosis intermedia de 1 miligramo kilo peso día. Lógicamente que tenemos también otras categorías dentro de los pacientes COVID. Todos llevan tromboprofilaxis, incluidos los ambulatorios. Tenemos el paciente crítico en UTI, aquel paciente que sospechamos trombosis venosa y o tromboembolismo pulmonar. Son diferentes esquemas con heparina de bajo peso. Tratamos de evitar la heparina no fraccionada porque el riesgo de de trombocitopenia inducida por heparina es mayor con la heparina no fraccionada que con la de bajo peso. Gracias.
Muy bien, doctor Minoldo, muchas gracias por sus aportes muy claros. Bueno, y nos vamos a cruzar el Río de la Plata y le vamos a dar la bienvenida a la doctora Paola Ortiz, que es especialista en flebología y nuestra referente en Uruguay. Adelante, doctora.
Bueno, muchas gracias por la invitación. Es un honor estar acá. So thank you for the opportunity. And Dr. Caprini, thank you very much for your lecture. Excellent, and always a pleasure to listen and learn from you. And I have the same concern as Dr. Naves. How long after a COVID infection we have to suspect that the patient is at risk for DVT? So, for example, if a patient came up to our office for a venous ablation, so we have to give 2 points if the patient had COVID 1 month ago, 2 months ago. Should we ask for D-dimers before performing these procedures? What is your recommendation about that?
First of all, for an elective quality of life procedure like working on the veins, I wouldn't touch somebody for 6 months. And I'm very conservative, but the thing is that if somebody has some most venous procedures can be delayed and treated with compression, and not just stockings. You've got other modalities that you can use. That's number one. Number two is that when patients come home from the hospital, initially I think that the first 6 weeks is critical, but then they need to be constantly reevaluated. At 6 weeks, are they still on oxygen? Can they walk 30 feet? Remember the definition. The best definition we have so far comes from Al Peshameen in the sub-analysis of the Metanox trial that was done in 2000. And that was a trial around the world where people were compared to either get low molecular weight heparin or standard of care in medical patients in those days. There was equipoise. In the patients that got low molecular weight heparin, in the patients in the control group, their incidence was 19% DVT. It was cut in half with the low molecular weight heparin. However, if the patient could walk 30 feet, which was the definition used for ambulation, and they were in the control group, instead of a 19% incidence, it was cut down to 9%. Now, if the patient was in the low molecular weight heparin group and couldn't walk 30 feet, 9% incidence, 66% risk reduction to 3.3% if the patient could walk 30 feet. So, long-winded answer to this, can the patient walk 30 feet? Is the patient on oxygen? And oh goodness, is the D-dimer still positive? And just doing a standard Caprini score, which is like a history and physical. And especially if the patient has any of the other patient's BMI is over 40, that type of thing, past history of thrombosis or family history of thrombosis, then I would continue protecting them until the D-dimer is normal, until they're back to full activity, and any of the other modifiable risk factors relative to the COVID have disappeared. And for God's sake, I wouldn't touch their veins.
Okay, thank you. And another, this is for COVID, severe COVID, or for all COVID, in fact, COVID positive, but with asymptomatic or asymptomatic COVID?
It's always the wrong word to use with Dr. Caprini, all, because we have to do a risk assessment. Those low-risk patients, the asymptomatic patients, or maybe they came in because they were anorexic and they just needed to get some oxygen for a couple of days. Now they're going home. Their D-dimer is normal. They don't have a high Caprini score. No, you have to make sure that you risk assess the patients and put them in categories and give them prophylaxis for the period of time that they need it, depending on their level of risk. Okay. So the simple patients, but in somebody so I think here's where you're coming from. Patient gets COVID, but the patient gets over the COVID, is non-seriously ill. The D-dimer is normal. Their BMI isn't 40. They don't have a lot of risk factors. You retest them and they're persistent D-dimer negative. Then, I believe you want to wait 3 months and vaccinate them. Then after the vaccination, a month later, do your beautiful procedure. Okay. And again, you're talking to, I remember I have 3 daughters. 2 of my 3 daughters are like I am, very, very conservative. And the other one is, Dad, get out of here. That's very uncommon that we're going to have a problem. So it depends. So all I'm saying is I'm giving you the ultra conservative view because I don't care about anything but protecting that patient. And if the risk is even low, so I'm still protecting them. So you have to take my answer in context about the kind of a mentality that I have, which is very protective.
Okay, thank you very much. I appreciate your view. Thank you.
Muy bien, muchas gracias, doctor Caprini, doctor Ortiz. Vamos a pasar a nuestro último panelista, que es el doctor Ernesto Intriago, presidente de la Sociedad Panamericana de Flebología y Linfología, que se encuentra en Ecuador, pero él está con una disfonía, así que yo voy a leer la pregunta que tiene para el doctor Caprini. Dice, congratulations, Professor Caprini, for your brilliant presentation. I would like to know when would be the ideal time to perform a treatment for varicose veins or sclerotherapy or endovenous thermal ablation or surgery in a patient post-COVID and discharged from hospital with elevated antibodies. What antithrombotic prophylactic measures would you recommend?
All right, so first of all, to repeat, I wouldn't do any venous procedures on that patient. Probably for 3 or 6 months, depending on the risk of the patient. The patient should have negative D-dimer. The patient shouldn't have any modifiable comorbidities like have to rely on oxygen or not being able to ambulate normally or have a BMI of over 40, that type of thing. So I would not do that venous surgery, certainly in a patient like that. Now, I assume what he's talking about is a relatively healthy patient, again, that has a minor infection, doesn't have residual, can walk fine, doesn't have a high BMI, doesn't have a positive D-dimer, and successfully got over either being infected with COVID at home or infected it in the hospital and still got over it and got home without a serious problem. That type of patient, I would first make sure that you wait the period of time recommended after COVID positivity to vaccinate them. And then after they're vaccinated, which I believe runs around 2 to 3 months, but that could be debated, whatever the regulations are in your country or whatever is recommended. I'm not an expert at the regulation. But the steps are, make sure the patient doesn't have any residual high risk, like a lingering high D-dimer or other risk factor. Number 2, that patient has gotten over the infection and has gotten vaccinated. And then following that, I would go ahead and do the procedure. But I would follow the tentative Caprini scores that we've set up for patients who are having varicose vein procedures. So if they have a procedure and it's done alone, whether it be with the endovascular ablation or laser, that you would add, if it's alone, you would only add 1 point, but if it's longer than 45 minutes, 2 points. Then if they combine it with phlebectomies or the power phlebectomy, then that adds another point, and the Michigan group has shown that that makes it higher. So in general, without giving you all the specifics of that, if that patient has a Caprini score of 8 or less than 8, I would still give them low molecular weight heparin for 7 days, or a DOAC for 7 days after the procedure. And then at the end of 7 days, if their score was over 8, certainly they should get prophylaxis for 1 week. And then if the score is higher than 8, then they should also have a scan at a week to make sure that they don't have anything brewing. And then you might consider giving them low molecular weight heparin or a DOAC for longer. But that all has to be individualized. But remember, you're doing a quality of life procedure. And the last thing you want is even one patient. I know you're all sitting there thinking, I do thousands of patients and I don't have a problem. You do one or two patients that gets a bad result, a bad leg, or even dies of a fatal pulmonary embolism, ruins your reputation, sullies the whole procedure, and you don't really need that. So that's why when I always did this, I always took the more conservative approach in order to protect not only the patients, but a lot of you skilled surgeons will have years of being able to do your skills. And if you get burned, that's going to inhibit your ability to do a good job. It's like a race car driver. Once they hit the wall, they're never quite the same.
Thank you very much, Dr. Caprini. Y ahora le voy a dar la palabra al profesor Kanata para que haga la presentación, por favor, de nuestro siguiente orador. Adelante, Víctor.
I wanted to add one more thing. I'm sorry, but I have, this video just came out today on YouTube and my other social media sites. And I put one out every week. And there are several videos that I've done for the phlebology societies that are available on Caprini Resource Center at YouTube. And if any of you can't get that, you send it to me. And that'll give you the exact details of what we say about varicose vein operation. And again, it's for all of you to test.
Okay. Tenemos que recordar de que agradecerle al profesor Caprini y seguir adelante. Anil, you are more than welcome to start your presentation. Please start it. Thank you very much for being with us and again. Thank Professor.
Thank you.
After speaking from Dr. Caprini, hearing Dr. Caprini speak, that's a very difficult act to follow. I'm going to be talking about something a little more mundane, about superficial venous thrombosis. It's not so benign. So when you look over the literature for superficial thrombophlebitis, you can get very confused very easily because there's lots of different directions that the literature has been through. And sometimes you feel like there are more questions than answers. Some of the things that we've known for many years, however, with superficial thrombophlebitis is the epidemiology and the demographics. And you look over these risk factors and they look somewhat similar to what you might expect for DVT. And indeed, if you look at the risk factors for superficial thrombophlebitis, again, many of the risk factors look very similar to those of deep venous thrombosis that we've known for many, many years. However, the location is a little bit atypical for superficial thrombophlebitis, and the majority of them are along the distribution of the greater saphenous vein, less so for the lesser saphenous vein, and even less so for the upper extremity. Prior literature had suggested that superficial venous thrombophlebitis was a benign condition. However, when you look a little bit closer, we suggest that maybe it's not so benign. We started our journey looking at superficial venous thrombophlebitis and looking at its the hypercoagulable state with SVT almost a little over 20 years ago. This is a prospective study in which we looked at hypercoagulable states. Again, it was a long time ago, and the majority of these patients that we looked at had superficial venous SVT alone. And from what was standard of care back then for hypercoagulable state, we subjected all of these patients to, when they came into the office, they automatically got a panel of tests done to see for what was standard back then for hypercoagulable state. And we find that 35% of the patients with only SVTs involving the lower extremity and the greater saphenous or the lesser saphenous veins had a hypercoagulable state that could be identified. In addition, when we repeated the test 3 times to see if some of these factors are transient, they still remain very high. Subsequent to our data, others have also confirmed these data, suggesting that even with superficial thrombophlebitis, that there's a pre-existing hypercoagulable state that may be contributing to these patients' thromboses. We suggested that based upon this data, that SVT is a deceptively benign disease and that patients with SVT may develop DVT and should be closely followed. Therefore, we tried to look at the incidence of SVT and DVT concomitantly. When we looked at just patients presenting with lesser saphenous vein thrombophlebitis, what was the natural history of these patients and what implications did it have on management? We looked at 32 patients who came into the office with lesser saphenous vein thrombophlebitis, and we found that a fair number of them had contiguous DVTs, and another 16% of them had non-contiguous DVTs, again, suggesting that systemic factors may be playing a role in these patients. When we looked at patients with isolated saphenofemoral junction thrombophlebitis, again, we found that patients had a high incidence of DVT in the contiguous veins and non-contiguous veins. And again, subsequent data have confirmed these findings that patients with saphenofemoral thrombophlebitis also have a not so benign history. Others have also looked, even Dr. Nicolaides has looked at superficial thrombophlebitis and found that a small percentage of patients, only 4.7% of these patients in this series, have PE associated with isolated SVT. When we look at the literature in summation in this clinical review of 37 patients, they found patients with superficial venous thrombophlebitis had significant incidence of DVT, PE, and propagation to DVT. Again, not consistent with the traditional ideas that this is a benign disease. So we can see that if it's not so benign, which patients need to be treated aggressively and which patients don't. The literature is very consistent with branches of the greater saphenous vein and distal infrapalpatile greater saphenous vein clots that they can be treated symptomatically. However, it's not so clear with the proximal greater saphenous vein or those approaching the saphenofemoral junction. Some have proposed that surgery may be helpful in treating these patients with clots in the proximal greater saphenous vein. A group from Cincinnati, a well-respected group that's quite busy of surgeons, looked at the role of operative management for greater saphenous vein involving the saphenofemoral junction. And this very skilled group, in about 41 procedures, had a small but not insignificant incidence of postoperative DVT and wound complications. These type of data suggested to us that maybe surgery was not the answer alone for this disease process involving the saphenofemoral junction. We had evidence that these patients were hypercoagulable. Some of the DVTs that occurred in this operative series were non-contiguous, and some of them were on the other leg, suggesting that maybe anticoagulation might be a role. In a small series of patients who had saphenofemoral junction thrombophlebitis, we tried to treat them with just anticoagulation. We define this as acute thrombosis of the greater saphenous vein within 1 centimeter of the saphenofemoral junction on duplex. This is just an example of a fresh clot at the saphenofemoral junction right adjacent to the deep vein. Patients underwent routine duplex imaging, and at this time period, we were treating patients with Coumadin for 6 weeks. if they had no DVT. Again, the majority of our patients had clots only in the superficial system. And when we followed up these patients on a mean follow-up of 5 months, we had no subsequent evidence of PE, recurrence of the clots, or complications of anticoagulation. And therefore, we felt that anticoagulation may be able to play a role in these clots involving the saphenophthalmal junction. When Dr. Wakefield tried to look at a meta-analysis of what available literature there was in the American College of Surgeons of ligating patients who had saphenophthalmal junction thrombophlebitis or anticoagulating them, he found that the surgery patients tended to have slightly higher rates of extension into the deep system. They had a slightly higher incidence of pulmonary embolization. And however, he did suggest that surgery had superior symptomatic relief from the pain associated with the thrombophlebitis. However, anticoagulation was effective in preventing the PEs that you saw with some of the surgery and seemed to have minimal morbidity. Based upon this review, he suggested that the data available was quite weak to compare, as did the Cochrane database, and he suggested that intermediate dose of low molecular weight heparin for at least a month may be advised for patients who have saphenophthalmal junction thrombophlebitis. Based upon this data, we can see a large body of retrospective cohort data developing. Next, I wanted to look at some of the randomized prospective data looking at SVTs. In this group, looked at 562 patients with superficial thrombophlebitis from Europe and randomized them to 6 arms: early surgery, low-dose subcutaneous heparin, compression, low molecular weight heparin, or oral anticoagulants. When they analyzed all their patients, they found that SVT extension seemed to be higher with elastic compression alone, again suggesting that there are systemic factors involved with these patients. They found no significant difference in DVT rates at 3 months between all of these 6 arms, and they felt that stripping had the lowest incidence of thrombus extension. The cost associated for compression alone was the lowest. However, that was associated with the highest societal costs because the patients had so much pain after the procedures, they couldn't go back to work, and they had increased days of inactivity. And the cost for the medical system was highest for the low molecular weight heparin. In the Callisto trial, which had 3,000 patients randomized between fondaparinux or placebo, and these are patients that had 90% of them had clots involving the greater saphenous vein, and they had to have an SVT at least 5 centimeters long in the vein. It excluded patients who were high risk, who were within 3 centimeters of the saphenophthalmal junction. So now we can start to see what Dr. Caprini was talking about, that some clots at the saphenophthalmal junction are very high risk. And then if they're not quite adjacent to the saphenophthalmal junction, about 3 centimeters away, we're calling them intermediate risk. They found that treatment with prophylactic doses of fondaparinux decreased the rates of thrombus extension, recurrence of SVT, DVT, and PE. So now we can start to see that by tailoring the patients in terms of their risk factors, not as aggressively as Dr. Caprini was saying, but the location of the clot, we can say that prophylactic doses, at least of fondaparinux, based upon the Callisto trial, may be effective. Subsequent to this, a very similar trial, the Surprise trial, took patients and randomized them to prophylactic doses of fondaparinux or rivaroxaban, Xarelto, for 6 weeks. They randomly assigned 50% of the patients, of the 470 patients, to either one of these 2 arms. And again, these are patients who had clots greater than 5 centimeters in length, involving mostly the greater saphenous vein distribution, about 90% of them. And then they followed the patients. And they found no significant differences for the primary outcome at 45 days or 90 days for the composite of symptomatic DVT or PE, progression of the SVT, and all-cause mortality, and for the individual endpoints. So, again, we can start to see that although fondaparinux you have to inject for prophylactic doses, rivaroxaban you can give a pill and maybe save some money because it's not as expensive in terms of administration and the medication, and you can get equivalent efficacy for patients with intermediate risk thrombophlebitis involving the superficial system. So now we can start to see that we're starting to develop some protocols. Anticoagulation for those high-risk clots involving the saphenofemoral junction or within 3 centimeters for at least 6 to 12 weeks with full-dose anticoagulation seems to make sense based upon the Cochrane database. We also suggest, as is the Cochrane database, that follow-up duplex ultrasonography may be important to identify those patients who are experiencing extension. For intermediate risk, for greater saphenous vein above the knee, in addition to symptomatic care, we suggest prophylactic anticoagulation for about 6 weeks. If the clot is greater than 5 centimeters long, which is the majority of the clots, or they progress to within 3 to 5 centimeters of the saphenofemoral junction. We also suggest full-dose anticoagulation for SVTs that progress despite therapy with prophylactic doses. So basically you failed the prophylactic dose and now we're going to bump you up to full-dose anticoagulation. Or those patients with the current SVT after cessation of anticoagulation. Because those patients seem to have a more malignant course with recurrent SVT. For focal thromboses involving, let's say, the branches of the greater saphenous vein, those very common clots that we see coming into the office, we suggest serial duplex imaging rather than clinical exam alone, because it really does help examine the extent of the clots and helps monitor the clots serially and in a very objective manner. We find that some of the patients that we think on physical exam just have superficial varicosities that are clotted. When we do a duplex, very often they're much more extensive than we think. If on serial duplex imaging, thrombus propagation is demonstrated, we provide at least prophylactic doses, even for the superficial varicosities, even below the knee, for at least 6 weeks, because those patients we feel have failed conservative therapy with symptomatic treatment. And we've had pretty good results with this. So now getting back to some of the other questions that people were asking about SVT after endothermal ablation, we find that while much of the literature look at EHIT after endothermal ablation, many of those patients with the EHIT are asymptomatic. In contrast, the patients that suffer from thrombophlebitis of the varicosities after endothermal ablation, with that large varix sitting right next to that the skin, they really complain about that clot. We have a lot of patients that come in after endothermal ablation who come in saying, "Doc, I had the pain and swelling, it's better now, but now I got this big red lump and it hurts like crazy." So we decided to look at our experience in 1,800 procedures with RFA and endovenous therapy, specifically looking at thrombosis, including EHITs and those clots in the varicosities. Not EHITs, but clots in the varicosities, those painful lumps that occur after endothermal ablation. About 10% of our patients, half of them were SVTs and half of them were EHITs, and the majority of the EHITs were indeed EHIT 1. We found that those procedures involving the greater saphenous vein were more likely, as compared to those involving the short saphenous vein, accessory vein, or perforator vein, more likely to have those complications with those small clots, which cause a lot of pain. And this is just an example that up to 12% of the patients who had greater saphenous endovenous procedures ended up with some type of thrombosis, and about half of them were involving what we would call an SVT. Other factors that were associated independently, besides being the greater saphenous vein procedures, were also using a laser, and larger vein diameter was independently associated with increased rates in this database for thrombotic complications. Okay, if we're going to be looking at lower extremities, we got to mention at least upper extremities, because every one of us sees these patients in our office. Patient had an endoscopy last week, they had an intravenous placed, and now they come in with small thrombophlebitis in the arm. How do you treat those patients? Well, this Cochrane database looked at parenteral, enteral, and topical therapies. So some NSAIDs, some intravenous therapy, or some oral therapy, some topical heparinoids. What worked best? They weren't really able to answer much of the questions that you might have. They suggested that the evidence is so low quality and the data is too preliminary to really assess the safety and efficacy. So unfortunately, we don't have a lot of data, and what little data we have for upper extremity SVT, which we all see, is not very well studied or very well examined. Based upon these data, we suggest that SVT is not so benign. It's associated with a hypercoagulable state. It can be associated with underlying malignancy, especially if it's recurrent, with Trousseau syndrome or Mondor's disease. We suggest that it has a small incidence of PE, recurrence, and DVT. So we also suggest an algorithm for treatment based upon the location of the clot, based upon duplex imaging, with those with low-risk clots, intermediate and high-risk clots. And the treatment options for low risk, of course, would be symptomatic. Intermediate, we suggest the prophylactic doses with either DOACs or low molecular weight heparins. And high risk, of course, is full dose anticoagulation for at least 6 weeks. Gracias. ¿Algunas preguntas?
Thank you very much, Dr. Hingorani. Very interesting presentation. Le vamos a dar lugar ahora a nuestros panelistas. Volvemos al doctor Bruno Naves, por favor. Me olvidé decir, presidente de la Sociedad Brasileña de Angiología y Cirugía Vascular. Lo único que le suplico, doctor, muy breve su pregunta o su aporte, en honor al tiempo. Gracias.
Solo dizer que I did a lot of surgeries in the past in these cases, but nowadays I do the same thing as you do. I totally agree. I use generally rivaroxaban in the middle of high cases, of course, in the doses of 10 millimeters of the full dose. That's it, the same thing. It's but I did many surgeries, but now I'm lazy. So rivaroxaban is so easy that it's better. That's it. But I think surgery works very well. But nowadays, rivaroxaban works very well too, so I decided to use. Thank you very much. Congratulations.
Muy bien. Muchas gracias, doctor Naves. Le damos la palabra al doctor Antonio Trigo, por favor, sus aportes o sus comentarios. Muy breves también, por favor.
Good night, Dr. Hingorani, and congratulations on the lecture on my question. On patient with saphenous vein thrombophlebitis, which laboratory research do you? Second, and what is your conduct in a patient with ascendant thrombophlebitis in the internal saphenous veins? Clinical or surgical treatment?
Sorry, I didn't catch the first question. It was broken up.
Doctor Trigo, ¿le puedo
One question.
Trigo, a primeira pergunta, Trigo.
On a patient with saphenous veins thrombophlebitis, which laboratory research do you do? And the second parent, and what is your conduct in patients with ascendant thrombophlebitis in the internal saphenous vein? Treatment, clinical or surgical?
We also have switched to anticoagulation with prophylactic doses for patients with thrombophlebitis with ascending. in all of these procedures. We feel that all of them, we don't feel that the greater saphenous vein is the only vein that is at risk for recurrence, DVT or PE. So even with the accessory vein, if it's coming up to the saphenofemoral junction, we go ahead and anticoagulate them with prophylactic doses. However, if they're coming close to the saphenofemoral junction on duplex ultrasonography, not by physical exam, by duplex ultrasonography, which is in contrast to some of the medical literature, which I don't agree with, because we've been very surprised sometimes. We think that a clot may not be as extensive on physical exam, and we got a duplex, and it's much more extensive than we actually think. So we are fairly aggressive. We stopped operating on most of these patients because of the effectiveness of anticoagulation. And quite honestly, I'm a surgeon, and I operate on these patients if I feel they need it. But the wound complications that we've had in some of these patients has not been small.
Thank you, Dr. Hingorani. Pasamos ahora al Dr. Moraes, por favor, lo más breve posible.
Sí, congratulations, Dr. Hingorani. It's a good topic because it's the life of the office. How do you treat a patient with SVT who discovered a gastrointestinal cancer with a high chance of bleeding?
Again, we try to talk about what Dr. Caprini was saying, that in terms of risk stratification. If a patient has an SVT involving the varicose veins, I watch them. I don't do anything. I put them on warm compresses and treat them symptomatically. If it's a patient involving the greater saphenous vein below the knee, that patient has a very small chance of progressing for complications. If a patient has a clot where let's say it's up to the saphenofemoral junction, that does not mean that this patient is going to extend into the greater saphenous vein, from the greater saphenous vein into the deep system and have a PE. The majority of patients do not. So in a patient who can't be anticoagulated, most of the time with serial duplex imaging and serial clinical exams in the office or by the bedside, you can observe these patients for the majority of cases. So I do feel that in those patients who can't be anticoagulated, I do feel that I still use compression in some of these patients if they're able to tolerate it. I do use warm compresses with conservative therapy for the outpatients. But for the inpatients, I get a duplex in 3 to 5 days and reassess if the clot's propagated or not. Most of them do not.
Okay, thank you.
Muchas gracias, doctor Moraes. Pasamos al siguiente panelista, el doctor Minoldo, por favor. Muy breve. Tiene silenciado el micrófono, doctor. Abajo a la izquierda.
Sí. Mis felicitaciones al doctor por su excelente presentación. En nuestra institución, en caso de trombosis venosa superficial, para indicar la profilaxis antitrombótica con heparina de bajo peso molecular, digamos, por la extensión del trombo, si tiene más de 5 centímetros, y si está a menos de 10 centímetros, por ejemplo, del confluente safenofemoral. Lógicamente que este tratamiento se mantiene durante 45 días y en esa ventana es prudente investigar causas hematológicas y no hematológicas que pueden haber gatillado el evento trombótico. Y si se asocia con edema, descartar trombosis venosa profunda, que es una de las complicaciones que podemos tener en esta situación. Generalmente las causas hematológicas empezamos a investigarlas después que el sistema hemostático se ha estabilizado alrededor de la semana 6 u 8. Con toda la batería investigamos la mutación Leiden del factor 5, la mutación 20-210 de el factor 2, inhibidor de la activación del plasminógeno, del TPA, perdón, si hay síndrome antifosfolípido o no. La hiperhomocisteinemia también la investigamos. Los niveles de factor 12, de factor 8, lipoproteína A, porque la lipoproteína A tiene una estructura similar al plasminógeno y compite con él, o sea que genera un estado de hipofibrinolisis, ¿no?
Muy bien, muchas gracias, doctor Minoldo. Bueno, le damos la palabra a la doctora Ortiz, por favor, brevísima.
Well, thank you very much, and congratulations, Dr. Hingorani. Excellent presentation, and I think that you have covered everything very clear. So only one concern, what do you think about the thrombectomy of the superficial venous? There is a future for that? What do you think about that?
To try to do various procedures with the greater saphenous vein. I don't think that thrombectomy is the way to go for these. I think that very often with just anticoagulation, they seem to resolve very, very well in many of these patients. And okay, granted, some of them do not, and they end up with a chronic superficial thrombophlebitis. But I usually don't feel for the greater saphenous vein that we need to worry so much about the thrombectomy. The results are, in terms of the venous outflow, only 4% of the blood goes up the superficial system as it is. So in terms of a physiologic loss of venous outflow, it doesn't seem to really make that much of a difference long-term or short-term. Interestingly, although we see COVID disease involving the deep system, I have not seen much COVID disease involving superficial thrombophlebitis, even with patients with very extensive DVT. So I'm not certain why. I mean, we've seen so many patients with COVID here in the hospital and outpatients. I'm not really certain why we're seeing such a difference in terms of the location of the thrombophlebitis in these patients. I just don't have a good answer yet. Maybe Dr. Caprini would have some answers about that, because as the patients present, they seem to present somewhat differently with COVID disease in terms of the distribution of the venous thrombosis. So getting back to what Dr. Minato was saying is that I think the hypercoagulable states might be slightly different between some of these, even though the literature suggests that they're very similar. Their presentations are different.
Okay, thank you very much.
Gracias, doctor Ortiz y doctor Hingorani. Bueno, pasamos ahora a... Teníamos un video, unos saludos grabados del doctor Lowell Kapnick. ¿Lo podemos ver, por favor?
I would like to thank the organizing committee for the privilege of summing up both excellent lectures. Let me start with Joe Caprini. As you can see, Dr. Caprini gave an excellent lecture on COVID-19 practice guidelines, current management in 2021 of the Caprini score for thrombosis. As you can see, Dr. Caprini recommended various treatment algorithms depending on the Caprini risk category. Dr. Caprini stated the following regarding risk assessment updates. The Caprini score increases in direct proportion to the incidence of clinical relevant VTE events. Identifying those at high risk varies according to the population tested, and the original concept that everyone with a score of 5+ is high risk is no longer true. Some patients with a score of 5 or 6 may be spared anticoagulants. The set point of high-risk patients needing prophylaxis is varied. Studies have now identified a very high-risk group that may benefit from extended anticoagulant prophylaxis. Dr. Caprini suggested modifications with regard to coronavirus-positive patients. Add 2 points for coronavirus-positive asymptomatic patients. Add 3 points for coronavirus-positive symptomatic patients. Add 5 points for coronavirus-positive patient score with a positive D-dimer. He concluded with regards to COVID patients that the original modified Caprini score equally predicts venous thromboembolism in COVID-19 patients. Studies identified a direct correlation between the Caprini score and the risk of VTE or unfavorable outcomes in COVID-19 patients. The score of equal to or greater than 7, as calculated at the admission, or equal to or greater than 11, as evaluated at discharge, predicts symptomatic venous thromboembolism despite pharmacological prophylaxis. The predictability of the original score may be improved by the implementation of D-dimer or specific COVID-19 points. However, the original Caprini score is essential to begin with. Regarding the core registry of 4,906 patients, it concluded that continuing anticoagulation after discharge in 13.2% of patients significantly lowered composite outcome by 46%. Comorbidities included hypertension, 38.6%, diabetes, 25.1%, obesity, 18.9%, and the improved D-dimer VTE score greater than 4 was one important predictor of increased VTE risk. I have one quick question for Joe. With the information with regards to SVT and DVT that are seeing in patients post-vaccine, would you add a point or points to your risk assessment? So let me switch to Dr. Hingorani. Another great lecture. Is superficial venous disease a benign entity? Simply put, it depends. Dr. Hingorani's conclusions. SVT and varicose veins are usually benign. Truncal veins near the junction and or greater than 5 centimeters, not benign. SVT in a truncal vein without previous pathology, not benign. Consider an algorithm for treatment depending upon the risk of SVT with regards to venous thromboembolism. Thank you, ladies and gentlemen, for the opportunity.
Bueno, muy bien. La verdad que hemos tenido una velada extraordinaria con panelistas y disertantes de lujo, pocas veces vistos. Así que le voy a dar la palabra al profesor Dr. Víctor Ganata para que nos cierre esta reunión.
Muchas gracias a todos mis amigos. Es muy difícil unir a tantos países así como hemos hecho hoy. I think we have a great day tonight with so many people all over the world. We have people from Brazil, the States, Argentina, Paraguay, Uruguay. Thank you very much to all. We did a great job. Sergio, your work was excellent. Thank you very much to everybody else. Also to the Quimfa, that is the pharmacy who helped us in that kind of huge, tremendous meeting that we have. Thank you very much to everybody else. Muchas gracias a todos, a la gente de Brasil, Uruguay, Estados Unidos, Argentina, Paraguay. Muchas gracias a todos y podemos dormir en paz. Gracias y muchas felicidades por la presencia de todos. Gracias a todos.
Obrigado, boa noite. Good night.
Se añua Rei potaro e gerurente Peisajina Paraguay Paipuque la Emiliano Ta ipuque la Yambay Yahamino Nyondive Yero Krihape Torbe ape Yahesape koe Aguille manteame Agüeruco señe Toiko subi pura hey, albu arito bebé, aguille manteame